Hi, my name is Veronica Hunter, and I'm going to be discussing constructing a revised fall policy, a study that I completed as a part of my senior practicum assignment. Hospital-related patient falls are the #1 cause for hospital-related injury across the world. The falls may be assisted, meaning a staff member is present during the fall, or they can be unassisted, meaning there's no staff present. Patients at high risk for falls include elderly patients, patients that may be on opioid medications, patients with an altered mental status, and patients with lower extremity fractures. Each hospital has its own fall policy in place to prevent patient falls. They may lead to injury and typically are put into place following a fall risk assessment. Through the use of a combination of a fall risk assessment, fall policy, and nursing interventions, we can drastically reduce the number of patient falls across the world. I created a short research-based study on a small med-surg unit within a hospital. I did implement that policy for a 2-week trial period to see if we can make any changes related to patient fall. The overall goal was to improve falls on the unit through my research and my policy implementation. After the implementation process, I did gather all the data that was collected, and I compared falls from the past 90 days prior to my implementation to the 2-week period where my policy was implemented. Here we have a graph that shows fall statistics on the unit prior to my 2-week trial period for 90 days. The data that was collected showed the falls that were on the unit from the dates of November 1st, 2020 through February 1st, 2021. Over the 90-day period, there were a total of 4 patient falls on the unit. The month of November showed 1 patient fall that occurred at night. December 2020 showed 1 patient fall that occurred during the day. January 2021 showed a total of 2 patient falls, 1 that occurred during the day and 1 that occurred during the night. While looking at these numbers, day and night ratio does seem even, but I did notice that prior to the 90-day review, there were more falls occurring during the night than during the day. It's my thought that this is because of the decreased staff and the decreased hall traffic at night. And that did play a huge part in my new policy implementation. The policy in place prior to my revision included the use of a Morse fall risk assessment scale. Each patient admitted to the unit had the assessment completed by the nurse, and standard precautions were put into place despite the fall score. Standard precautions include the bed being in low position and locked, the call light within reach, personal patient items within reach, and the floor remain free of clutter. Patient fall scores greater than 45 did warrant additional implementation measures, which included the use of a yellow gown, yellow socks, a yellow sign that was hung outside of the door, and a mat that was put on the floor next to the bed, and also the use of bed alarms. Hourly rounding was implemented on each of the patients during the day and before 12 a.m. at night. After 12 a.m., that hourly rounding was allowed to go to 2-hour rounding just to allow patients more rest during the night. The first revision that I made to my revised fall policy was for the nurse to complete fall assessments more frequently. This included doing a fall assessment at the admission that he or she typically would, and then with any change in condition. And this means any change in physical condition, any change in mental status, or if they had a fall, of course, they would do another fall risk assessment at that time as well. The second change that I made was implementing hourly rounding 24 hours. This means that after 12 a.m., instead of being rounded on every 2 hours, all high-risk fall patients were rounded on every hour. By eliminating that 2-hour rounding rule after 12 a.m., high-risk patients have eyes laid on them every hour as opposed to every 2, which can prevent near falls or patient falls. With hourly rounding, I also enforce checking of bed alarms, ensuring that they're on and in working order. Doors will also remain open at all times for all patients of high risk, unless they refuse, and of course that refusal should be thoroughly documented. The third revision that I made was explaining to patients what fall risk is and what their score means and all implementations that were to be put into place. Studies have shown that explaining things to patients gives them a sense of involvement in their care, helping them to understand a little better, and that therefore increases their compliance and quality of care. And there should always be time for patients to ask questions, and all questions should be answered to the best of the nurse's ability. During my 2-week policy implementation period, there were no falls on the unit. While I can conclude that my policy was effective, there were some errors that I noticed made by staff that could have ended in a patient fall on the unit. During hourly rounding throughout the night, I noticed that a bed alarm was broken and not turning on. The patient in that bed was a high-risk fall patient, so I immediately removed that patient from that bed and put them in a working bed, removing that broken bed from the unit and seeing that it was fixed as soon as possible. I also noticed that a few times coming onto shift, there was some documentation that the call light, the bed alarm was on when it in fact was not on. This poses a huge problem, as nurses should never document what has not been done. This is considered false documentation and can lead to legal trouble if taken to court. I also noted that bed alarms were being left off after providing patient care. This is also a huge problem. Educating staff, especially those who are not as involved in patient care, on the effects that could happen if bed alarms are left off is important. Sometimes education isn't initially provided, which can cause mistakes to happen. While my 2-week trial period ended in success, I do think there could have been some benefit from a longer trial period. These errors were noted and the nursing manager was made aware for any further nursing education that needed to be provided on the unit. Through proper education, staff education, and patient education, we can dramatically decrease the number of hospitalization patient falls and reach our overarching goal of providing the best patient care possible. Thank you for listening.